So Parkinson's UK is our national charity that we're supporting this year. So I'm delighted to welcome Tracy Ward from Parkinson's Disease UK and two of the Parkinson's specialist nurses who support our community to this lecture. So it's my great pleasure to welcome you to tonight's session. I have the privilege of hearing from one of our foremost experts in the field of neurology, Professor David Byrne from Newcastle. As many of you know, Professor Byrne is a distinguished clinician and researcher with a particular focus on Parkinson's disease and other neurodegenerative disorders. His extensive work, including contributions to clinical guidelines and groundbreaking research, has significantly advanced our understanding of Parkinson's disease and its management. Tonight, he will be sharing insights into the most recent advances in Parkinson's disease, covering developments in diagnostics, therapeutics, and our evolving understanding of the disease's pathology and physiology. This is a subject of great importance to people living with Parkinson's who are in the audience and supporting those with Parkinson's who are in the audience, and as clinicians, given the growing prevalence of Parkinson's in our population and the challenges it presents in practice and in life. So we are truly fortunate to have him with us this evening. Please join me in welcoming Professor David Byrne.
Great. Well, good evening, everyone, and thanks, Tim. That's a really lovely, kind introduction, and it's just been so lovely to come here and see a few fantastic faces, both new and old. And I had no idea, to be honest, that one or two colleagues who I've already said hello to were members of your wonderful society. So it's a real pleasure to be able to come here and to contribute to this society and to be here in this absolutely beautiful setting. It's wonderful. So I really wasn't entirely sure to the audience that I would be speaking tonight. I know you're all incredibly bright and intelligent people, and all from very different walks of medical profession, be it nursing, be it medical, be it respiratory disease, and so on. So you'll forgive me if some of what I'm going to say might seem to some of you a little basic, and then I'll try and sort of have the old pyramid approach where perhaps for those who are more expert in the area, you might be able to at least learn one or two things, I hope. But this is the sort of outline of the lecture. So I'm going to give a resume of Parkinson's. So this is the slightly more basic element, if you like. And then I'm going to sort of fast forward into these other areas. It's obviously a bit selective, I have to be honest, because there's so much going on at the moment, and it's a rapidly changing area. So if I haven't included your favorite trial or something that you're aware of, I forgive me. The secular trend for Parkinson's is actually towards one of increase. And I think that, it is, as Tim said, second to Alzheimer's disease. It's the second most common neurodegenerative disease in the UK. It's found worldwide. And I always say to the medical students, if you can't remember numbers, 1% of people over 65, 2% of people over 80 have got Parkinson's. There's a little bit of a general feeling at the moment that, as well as the fact that we've got an aging population, there's some recent literature that's come out looking at whether occupational and environmental toxins might also be having an effect on increasing the prevalence of Parkinson's, things like pesticides and the like. And there's a bit of a move going on, actually, which we're aware of in the Movement Disorder Society about, trying to ban things like paraquat. But the problem with that is the unintended consequences that might lead to in poorer countries. So I'll just give you that as a sort of a food for thought. The bottom line is it is very common, and there's sort of prevalences on the right here. I mean, I think you wouldn't want to live in Rotterdam, judging from the slide there, but it makes the point that the age is the biggest risk factor. But Phil, who's in the audience, and I know sees bucket loads of people with Parkinson's, will attest to that actually we've all had examples, sad examples of citizens who've developed Parkinson's at a much younger age. And all the epidemiological studies would show a slight male preponderance. Unclear, is it a sort of occupational exposure, or are there hormonal effects or protective influences perhaps in women? That's never really been determined as of yet. We're talking about Parkinson's disease, but as some of us know, making an early diagnosis is actually not that straightforward. And as I always again say to lectures and with students there, you know, all that shakes isn't Parkinson's. And if you actually ask somebody down in the freezer section at Marks and Spencer's, you know, what is the defining feature of Parkinson's? Probably 9 out of 10 would say tremor, and they would be wrong, because the defining feature is bradykinesia or slow movement. But of course, a lot of the time, the mimics, the things that we struggle to differentiate, do have tremor. So essential tremor, dystonic tremor is another thing that can sometimes mimic Parkinson's. And it's well known that a number of patients who've been enrolled in trials of Parkinson's new therapies have never had Parkinson's at all. And they're not insignificant numbers in some of those cases. So drugs, of course, can cause anything, and anything ending in zine, you would have to take be concerned about. That can absolutely mimic. I remember the case, and Phil and I worked for the same consultant many moons ago up in Newcastle, who had sent me a patient on when I was a young consultant, asking about brain surgery, deep brain stimulation for Parkinson's. And it turned out the person had been taking prochlorperazine or Stemetil for dizzy turns for many, many years, had not declared it. And in fact, it took a bit of digging, and she finally declared it, stopped the drug, and she came back several weeks later and it had all vanished. So it's as well that we hadn't done deep brain stimulation on her. So I think, you know, you've got to be antennae well tweaked. And then there are the ugly sisters, as Michael Coe at the PSP Association used to call them, multiple system atrophy, PSP, which early on can sometimes mimic. And the sort of golden fleece very much is trying to find biomarkers that can differentiate these conditions at a very early stage. So getting an accurate diagnosis. What we also know is that Parkinson's has got generally a specific pathology. This is a slight generalization in terms of the Lewy bodies. You can have Parkinson's without Lewy bodies, but by and large, it's the defining feature of the vast majority. And the sort of pathology, as you can see on the left here, and you can remember your brain stem anatomy. So here's the midbrain, the peduncles, and you've got the substantia nigra. And I always say to the medical students, you know, if you want to fool the punters in neurology, you just give it a Latin name. So black stuff, it's all pretty good. And then if you're not sure, you look at the pons, and you've got the blue spot or locus ceruleus. So that is kind of the classic depigmentation that you then see in this smudgy, depigmented midbrain of somebody with Parkinson's, and a slightly less comparable, but again, depigmented locus ceruleus. And the zooming up to a neuron, you've got here surviving neuron, and what looks like a fried egg in it here is a Levy body. Now, Levy is the kind of correct pronunciation, but the Americans converted it. I think it must have been the Mickey Mouse effect with Huey, Dewey, and Louie. So they converted it to Lewy body. And in fact, when I was going through this slide set this morning, I actually corrected this, because this is the stone on the grave of Friedrich Levy and his wife Flora, and that is actually in Pennsylvania. And you can see the eagle-eyed amongst you, because it doesn't project terribly well. It was sent to me actually just this year by a couple of friends in the Movement Disorder Society who went on a visit to the grave. There's an E in there, so it's actually Lewey. But this is the pathological hallmark of the vast majority of people with Parkinson's. Now, some of you will know that one of the major breakthroughs in Parkinson's, and which has then led to a therapeutic focus, possibly an obsessive focus, one might say, has been the discovery of alpha-synuclein within the Levy body. And alpha-synuclein protein we all have, and as the name suggests, it's a combination of location both within the nucleus and in the synapse. And what the story about this is just incredible, quite frankly, because This was a pivotal paper in a very high impact journal, the Annals of Neurology, in 1996 by Larry Golby. And this was looking at a contursy kindred. There was a huge family with Parkinson's. I was going to show the family tree, but take it from me, in that publication, it's just a very, very large kindred. And he did this clinical genetic analysis, and he realized clearly this was an autosomal dominant form of Parkinson's in this kindred. So note the date, it was 1996. And then later that year, in another not too shabby journal, Science, they mapped the gene in that kindred. Polymeropoulos, who he was involved from the genetics aspect in this contursy kindred, mapped it to this chromosome 4 locus. Again, notice the date, June 1997. So within the year, they had then found within that locus on the chromosome the alpha-synuclein gene and a mutation therein, which was clearly causal of Parkinson's in this family. And then a little bit later on, it was found because, and again, I know there are some really top-notch scientists in this audience and colleagues in all sorts of backgrounds, but my understanding as a non-geneticist is that some techniques that you look to screen the genome, they don't always pick out mutations. You have to use other specialized techniques that will quantify. And in fact, because of that need to do that different technique, effectively, this dose effect had been missed because there was a triplication in this kindred that Andy Singleton found. And that therefore showed, if you like, that not only if you have a mutation in the synuclein can you lead to Parkinson's, but if you have too much synuclein produced because of a triplication of the gene, you can also have a dose-related effect and causing of Parkinson's too. So this galvanized the whole field of Parkinson's, and it really was a pivotal moment. And I'll come back to synuclein a little bit later in lots of different guises. Now, when you can give a lecture like this and you can be a bit selective, it gives you a chance to show pretty pictures. And this is just remarkable, because what I want to get across here is not only are the techniques that we've now got available to look in unbelievable detail at microcellular level. So this is actually looking at tau protein in individual brain cells and organelles. It's really remarkable. But the main point of this slide is to say that while synuclein is clearly very important in causing Parkinson's, it's not the whole story. And proteins like tau and amyloid, which you will know about in the context of Alzheimer's, may also have synergistic effects. And in some cases, people wonder whether, in fact, things like tau are also very important in the pathology of Parkinson's too. Certainly, the area that I was, if you like, more known for, or am most known for, the dementia associated with Parkinson's. There is no doubt that this interaction between these proteins is really, it's not just the sum of the parts, it's greater than the sum of the parts. So it's not all just about synuclein. Okay, so this is then the sort of slightly more, if you like, back to the basics, but we'll move on from a bit of the science and have a bit of light relief on the clinical side. So the classic motor sign of Parkinson's is bradykinesia. That's the defining sign. And you all know that you would elicit that by getting somebody to do fast finger taps, and don't just stop immediately, watch them for a while, because the decrement can then become, you know, more evident. And we look at that in all sorts of other ways, but that's the classic. The classic tremor is the rest tremor, but it will appear in posture after a period of time. The tremor can then emerge. The rigidity is classically cogwheel or lead pipe, and if you're not sure, you get the person to reinforce by doing a maneuver with the other arm, and then feel the wrist with them doing that, or just lift a bottle or something off the bedside locker. Postural instability is early in MSA, multiple system atrophy, and progressive supranuclear palsy. Classically, the person will fall backwards in progressive supranuclear palsy. In multiple system atrophy, they tend to be more flexed and will tend to fall forward. In Parkinson's disease, it is a late feature in the vast majority. Again, Parkinson's is not just a motor disorder. It is got some really difficult to treat non-motor features. they can also predate the onset of the motor syndrome. So loss of sense of smell, and they always sniffing sticks and various other wonderful things. Upset testing, oil of wintergreen, oregano are smells that tend to be lost, it is said, relatively early. REM sleep behavior disorder. For some reason, men seem to have more violent dreams playing in goal for Sunderland, perhaps. Not that they have much to save these days because they're always attacking. But I think that, lashing out, hurting your bed partner, throwing yourself out of bed. Subdurals have been reported in this because of head injuries from falling out of bed, and can predate by many years the onset of the motor syndrome. Constipation and depression, anxiety, pretty non-specific, but they're clearly linked statistically as early non-motor features. And then the late complications, I mean, the psychosis and the dementia, really difficult to manage. And there's this terrible tension between managing the motor features and sometimes worsening these non-motor features like psychosis. So that is a really a major unmet need, I would suggest, in the management of Parkinson's. And it's great that there are nurses here and possibly listening in by Zoom, and it's great to have colleagues joining in that format as well. And we all recognise that a multidisciplinary approach is so important. It's not all about the drugs. So there are many, many different things that can be done, some of them incredibly simple, but that make a big difference. One of the things that I've learned, and I'm sure Phil, who sees, as I say, huge numbers of Parkinson patients, appreciates as well, is that I've had many, many trainees through the clinic who are care of the elderly trainees, and they are really great. And I learned from them because I was not told about when to do a DEXA scan and what to think about in terms of managing bone health. But of course, it is so important in an older age group that you have to try and protect against fractures if people fall. So it's simple things like that, that prophylactic measures that can make a huge difference. Okay, so there are some of us who've lived through an awful lot of change, and one would argue cyclical change in the management of people with Parkinson's. And we all know, if I asked Tim what year Cinemet came in, it was a very auspicious year, Tim. It was a year that a Northeastern club won the FA Cup. So 1973 was the year that Cinemet was first introduced. It had obviously been used as neat levodopa by Kotzias some time before that, in 1969, and had made people very, very sick because they were giving it as 8 grams, up to 8 grams of levodopa. And of course, that was peripherally being converted and making people very, very sick and very faint. The dopa decarboxylase inhibitor that went into Cinemet, or co-carol-dopa to be politically correct on the name, I still call it Cinemet, it was great. 74, a year that was less good for the Northeastern football, those Newcastle supporters, was when Madapar came in, and that again was a revolution, and there's very little between the two drugs. Then many of us benefited in lots of ways from dopamine agonist craze that came along. And I think it's fair to say that it's gone a full circle with dopamine agonists, that they are still used sparingly, but one would have to say that they don't really hold the promise that a lot of us thought they might have in terms of so-called levodopa sparing. So a lot of neurologists, a lot of care of the elderly doctors, they're all back to using levodopa, but we use it far more sparingly now. And you don't see a lot of the problems that, we used to get, where people were given large doses early with levodopa, and you would then see this terribly dyskinetic patient coming into your clinic, profusely sweating, possibly a little bit hyperactive mentally, and then watch them outside, and within a relatively short space of time, watch them suddenly go under and off, and then self-medicate and back up again. It does happen, and you do get these wearing off and peak dose dyskinesias. Of course we do, and that's still a challenge in the management. But there's just they're less damaging and less prevalent than they used to be in just about everybody's experience, I would suggest. We found with, for example, dopamine agonists, and we'll all have these horror stories. I mean, one patient of mine, I remember vividly, who was taking a dopamine agonist, basically said he wanted to gamble until it hurt. And he got banned from a local casino at his own request because he lost the house in terms of gambling excessively. The old ergot-related dopamine agonists like pergolide and bromocriptine could cause dreadful fibrotic-related problems. Both the tricuspid valve seem to be prone, and also retroperitoneal fibrosis and pulmonary as well, rarely as well. So they sort of went out of favor. Then the non-ergot agonists came in, like pramipexole, ropinirole. And then, of course, they ended up getting associated with the addictive behaviors. And the manufacturers ended up sailing really close to the wind in terms of group actions because of the problems these caused, because it wasn't just about gambling. Again, we've all had examples where people were taken to court for sexual misdemeanors because of hypersexuality in relation to that. And then the good old-fashioned amantadine, which I will come back to right at the end, causes this rather bizarre wood and reddened rash called livido reticularis, which is still not a bad drug, I would say, amantadine in a lot of situations. When you do get more advanced Parkinson's, we've got a bit more in the armamentarium now. So obviously apomorphine's been around a while. We've used a huge amount of continuous subcut apomorphine. Phospholipid kid on the block, new preparation is given subcutaneously of, again, a dopa preparation. It's just a different way of giving it, hopefully easing out the absorption from the stomach by bypassing that and giving it subcut. Duodopa, which is a dreadful name because it's given in through a tube into the jejunum, but it's a form of liquid gel, which is given in, again, there are different variations on a theme there. But again, in people with terrible fluctuations, that can be, again, a game changer in the right patients. And then deep brain stimulation, which at the moment, still really the target of choice would be the subthalamic nucleus, because you basically get help for all the cardinal symptoms and you can reduce the drug dose significantly that the person's taking. Okay, so there's a sort of primer / resume. So early diagnosis towards a diagnostic framework. I thought I'd put this in because from the Movement Disorder Society perspective, this is a really hot area at the moment. And I'm involved in something that's going to sort of kick off, well, it's kicked off now actually, but it'll kind of hopefully come to fruition in February next year, where we're trying to pull together a number of parties who've come up with these different approaches to the early diagnosis using biomarker. And I think what we would have to say is that this is such an important area, because by the time in neurodegenerative disease you come in with a lot of therapies that are putative neuroprotective, you would obviously have lost an awful lot of nerve cells by then. And by the time you are diagnosed with Parkinson's, you will have lost a number of nerve cells, quite a significant number, unfortunately, from the substantia nigra. So to be able to get in early, ideally before those symptoms have started, would make a huge difference just on first principles. And there are ways that you can try to do that. So obviously we can look at the clinical biomarkers like REM sleep behavior disorder that I talked about, like anosmia. And of course, there are studies that have been done in very large populations where through very simple means like scratch and sniff tests, by tapping on a computer keypad to measure bradykinesia, albeit at a very subtle level, and by asking certain key questions about sleep, you can get an enriched sample. But there are other biomarkers that one is looking at. And to try and get in early, for example, if you then took those patients and you then did a lumbar puncture on those patients, you would then think about, well, if that person was positive for a biomarker, then that would be the sort of patient that a drug would have the most beneficial effect on before they'd even developed motor symptoms. So with all of that theoretical framework in mind, there were two groups that published in the Lancet Neurology earlier this year. And I think it's fair to say it wasn't quite a world war, but it's been quite difficult for us to try to work with these groups. This group has been largely promoted by the Michael J. Fox Foundation, which have got huge amounts of money in America. I mean, literally money is no object almost. This group, more rooted in, I think, colleagues who have had a lot more history with the Movement Disorder Society and who've tried to adopt a slightly more flexible approach. And there's touch points between both. We then put out this statement around the same sort of time, trying to sort of talk about biological definition, staging, and classification. Anyway, without getting into the minutiae, because this is probably a little bit kind of, might seem esoteric, but what we're going to try and do, and what we are trying to do, is to bring the two groups together in a framework which is just literally gone out to the various parties taking part from both camps and others beyond in February, to have a clinical, a wet biomarker imaging type of level and genetic level as well that they would map onto. Because the danger about this, when you're relying on lumbar punctures and you're relying on a test, which is the seed amplification assay here, which is basically at the moment, it's yes or no. So you do a lumbar puncture, you take the fluid off, you do the seed amplification assay, and you're looking for, guess what? The protein that I talked about earlier on in the lecture, synuclein. And alpha-synuclein, you're looking for in minute amounts. But this amplification assay, as the name suggests, can boost up the signal. And after a period of time cooking, so to speak, you then either get a positive result or a negative with a threshold. Now, A, not everybody can have a lumbar puncture. B, seed amplification assays are not available in Africa and the world over. And do you really need to have that if somebody looks like they've got early clinical Parkinson's and you want to involve them in a drug trial? So that's what we're trying to capture here, as well as leaving the door open for advances in the field that might allow quantification of the synuclein signal, for example. We're also moving much more now to taking blood-drawn biomarkers, and that would be incredibly helpful to be able to look at synuclein, or in a skin sample. You can do punch biopsy and look for alpha-synuclein in skin biopsy. So if that can all be validated, that will be a game changer in terms of trying to get early biomarkers without having to be invasive and only have them in places where it can be afforded as well. Okay, so quickly moving on, just very few brief slides here. It won't surprise you to know, based on what I've just said, that there's a massive bias in a lot of the genetic and clinical studies that have been done. And I just slide to draw this to your attention. It's sad, but a lot are Caucasian, a lot are of European origin or North American origin. And fortunately now there are some initiatives around the world that will be drawing on and are drawing on samples from Africa as well, and they're already yielding really interesting results in genes that we thought had certain mutations that were very common in white Caucasian population, but certainly there are different variations of that in African populations. And of course, it could also influence the generalizability of therapies. So, you know, not everybody responds in the same way to drugs. So that's been a problem that needs to be addressed. There's been all sorts of look, and you know, I've talked there before about loss of sense of smell and REM sleep behavior disorder. Well, actually, if you look, it's probable that they may predict a more aggressive approach with dementia being in common. Oops, I've got an unstable connection. So, and then impact of type 2 diabetes. There's been a lot of debate about the use of drugs to treat diabetes in Parkinson's and whether there's an association of diabetes with Parkinson's at all. I think the jury's still out on that one. Again, an excuse to show a very fancy imaging. I mean, just unbelievable images. These are like real human brains where they've kind of taken the signals and have kind of can map areas like the fornix. You can look at the locus ceruleus that I talked about before. You can look at the size of these nuclei in the brainstem, and you can see whether they associate with symptoms like dementia. So the cholinergic nucleus, basalis of Meinert in the brainstem, people have literally stereotactically mapped it out and can show that in people who are more likely or have cognitive impairment in Parkinson's, they have smaller NBMs, suggestive of loss of cholinergic nuclei or cholinergic neurons. So incredible, powerful techniques now, and they will help to monitor things going forward as well as we introduce new drug therapies on trials. You can use PET, positron emission tomography, as a biomarker for gait. So this is a study from a group in Newcastle, a colleague who I've worked with many, many years, Lynn Rochester, and it's basically looking at different gait parameters, particularly step velocity and step length, and seeing how networks in the brain co-associate and co-vary with those different parameters. So it's not just for the fancy pictures, but what it does mean is you've got objective biomarkers to be able to look at the efficacy of interventions, albeit in relatively small trials, because it's not an easy or a cheap investigation. Again, coming back to our friend alpha-synuclein, this would be the golden fleece for PD imaging, and we're nearly there actually. So we've got traces in the brain, which you probably know about, that you could image, particularly for amyloid. So amyloid tracing to look for people with Alzheimer's or at risk of Alzheimer's is here, and it's in service. Tau PET tracers are available, and they are being used to characterize patients with what we call tauopathies, things like progressive supranuclear palsy, but also conditions like frontotemporal dementia. But alpha-synuclein has eluded so far the chemists and the ability to develop a tracer. But as I say, and without going into the detail, this is now, I think we're within touching distance. And if I were to do this talk in a year or two's time, I might be able to actually have shown you a picture of an alpha-synuclein scan in somebody with Parkinson's. And that would be incredibly helpful, both from a diagnostic, but also a monitoring perspective as well, we hope. Okay, so then moving on to the new approaches for intervention. Well, there's a busy slide. So that's one that's produced every year by this soul, Kevin McFarthing. He does this every year, apparently, Journal of Parkinson's Disease. And just to walk you through it, firstly, if there are people listening or present with Parkinson's or knowing somebody with Parkinson's, what Tim asked me to try and do is to kind of give you a message of hope. And that's easy because actually, I hope already you realize that we know far more about Parkinson's than we ever did when I certainly started out in neurology, and even 10 years ago now as well. So it's happening and going up all the time, this level of knowledge. And the drug companies, having gone through a bit of a fallow phase and having had their fingers burnt by losing billions literally on drug development, have kind of come back into the fray in recent years. And so this slide effectively divides up disease-modifying therapies kind of in the northern hemisphere and symptomatic therapies in the southern hemisphere. And then you've got it's slightly artificial, as we all know, but the phase of drug study. You've got your phase 1, the very early experimental type work. Phase 2, experimental medicine, where you're really looking for signal and hopefully some sort of will to carry on. And then phase 3. Now, the slight, if you like, downside on all of this is you can see that whilst the phase 1 and phase 2 on disease modifying is healthy, sadly, phase 3 is pretty sparse. Ambroxol, to the eagle-eyed amongst you, and actually that really doesn't project well, I can see it better on here, but that's Ambroxol, that's cough mixture. John, where's John? That's cough mixture, John. So
I told you the answer.
Yeah, absolutely. Respiratory physicians have always had the answer. And yeah, I mean, so that Tony Shapiro at Royal Free's been doing a study looking at Ambroxol, because it might work on an enzyme called glucocerebrosidase, and that's also been implicated in Parkinson's too. Exenatide, I think I'm allowed to say this, I was on a trial steering committee looking at a trial that Tom Fultony was doing at UCL on exenatide, multi-center study actually that involved several places in the UK. This is a drug which you'll all know, I suspect, used to treat diabetes. And there were high hopes for this from an earlier study. Sadly, and take no pleasure out of this, having been probably one of the first to see the results because I was on the safety committee, it was negative. So it's been gutting for the investigators because they really hoped that this was going to give some signal. So I think, unfortunately, that would have to almost come out of there because I can't see it's going to progress at this stage now. But the point is that these have all got to work their way around, and you may get better runners and riders working their way into phase 3 as time goes by. This is a very dynamic situation. And then symptomatic, well, it speaks for itself. There's a lot more populating the phase 3 area. And again, a nice healthy pipeline, particularly phase 3, that'll hopefully pull through there. So there's a lot of hope on what's happening. Now, again, sorry to keep banging on about it, but we're back to alpha-synuclein again. You're sort of saying, well, they must be pretty sure that alpha-synuclein is a pretty key player in this Parkinson's. And I guess there is a lot of evidence that it is, as I said at the start. So wouldn't it be a great idea to try and bring in vaccines to try and actually strip out synuclein or prevent it forming in the brain? So that's been the kind of approach that's been taken. So this is a relatively sort of early phase study of a first-in-human study, as you can see, with an alpha-synuclein peptide vaccine. And all I will say on this was that it was generally safe, well tolerated, and it did induce anti-synuclein antibodies, not only in the serum, but also when these brave patients who took part in this had lumbar punctures done as well. So it suggested that there was target engagement as well. So and that the vaccine penetrated into the CSF, and that's no mean feat, because you'll all remember the blood-brain barrier can be a devil of a thing to get vaccines and bigger proteins across. So that's encouraging. What's less encouraging, unfortunately, were back-to-back papers that the New England Journal of Medicine managed to collar in 2022, and you can see these tongue-twisting names. So thank God I only had one glass of wine. So cinpanemab and prasinezumab. I've been practicing those on the train because they literally were presented back-to-back papers with big editorial, and you can see in completely different companies, completely different groups, but remarkable similarity in certain dimensions, both in terms of the size of the studies, but also the kind of endpoints. And that's kind of no surprise, because we do only have limited current endpoints that groups like the FDA would accept. So the primary endpoint's a clinical one, and it'll be a scale Phil's very familiar with. The second one, the secondary endpoints, included imaging, and this StatSpect is a way of looking at the dopamine system in the brain. And the sad bottom line is, which you've all read by the time I've stopped talking, is the last bullet point. And I'll just show you, I'll just click to the second slide as well. So the left is the cinpanemab, the right is the prasinezumab trials. And you don't need me to tell you that those, sadly, those curves are not showing any divergence at all. So huge amounts of money committed here. Done some data dredging on the prasinezumab study, and they've sort of got subgroups which they think might show more benefit. And as soon as you start doing that, you start to see people thinking, really, you know, is that a real effect, etc., because it wasn't in the primary analysis. So that's frustrating, but they're down but not out on that, I would say, that things are still happening. Now, what I haven't talked about is another key player in the world of Parkinson's, which came along after the gene mutation for alpha-synuclein was found. And this is a LRRK2 mutation. Now, this is a kinase gene, and unlike synuclein triplications and synuclein mutations, which are as rare as hen's teeth, LRRK2 mutations would probably be in around, what do you reckon, about 2 or 3% of your patients, I think, something like that. Maybe a few more, maybe a few less. The big European mutation is a G29S mutation, and that's one of the examples that I was referring to before, where those mutations can vary in big populations, but it gives us a target. It's a gain-of-function mutation, and so what they're looking at are inhibitors of LRRK2. And it's a very active area now to try and see whether in that 2 to 3% of people with Parkinson's with LRRK2 mutations, which are relatively easy to test for actually, that giving these drugs could actually have a beneficial effect on the Parkinson's. This is going to horrify some of you, but particularly those who might have a predisposition to gout. But there's still, it's been hard to debunk the idea of oxidative stress in Parkinson's disease. And there was some anecdotal evidence that by using inosine, which actually raises urate, which is an antioxidant, be able to have a beneficial effect on early Parkinson's progression. So this trial, believe it or not, used inosine, blinded titration to get the urate concentration up. And without hanging around here again, because you're reading as I'm speaking, you can see that again, another negative trial, but sadly, the side effect you might have predicted, that there was an increase in kidney stones in the inosine receiving group because of that raise in urate. So at least it was convincing that it was raising the urate, but it certainly didn't help with the Parkinson's. So that's been another well-conducted trial recently released only in the last couple of years, which sadly was a negative. This is one that's not dead yet. This is nicotinamide adenine dinucleotide boosting, if you like, trying to boost that with nicotinamide riboside supplementation. And that's the idea of trying to raise cellular energy levels. And this is an early study that was published about 22, I think it was. And this is still work in progress. So these NR-safe NO-PARC phase 1 studies are ongoing to try and explore this further. So all I'm trying to show here is a range of approaches from the more fundamental, scientifically grounded with a genetic mutation, right through to sort of mechanistic, where we think there could be oxidative issues, for example, and trying to target that and/or the uric acid story. So trying every which way. This is another amazing approach, which you just think you can't make this up. This is an ABL kinase, again, which is thought to be overactive in Parkinson's for reasons we don't need to go into, but that it's thought to be a key player in synuclein aggregation, and it's the oligofibrils of alpha-synuclein that do the real damage. So if you can prevent the alpha-synuclein from sticking in small groups, clumps, you may have a beneficial effect. Now, I don't know are there any hematologists in the audience here, past or present? No, not seeing any hands. So the ABL kinase, one of the drugs that was used originally to look at this effect is being used, as I recall, to treat chronic myeloid leukemia. So it's a pretty toxic drug, and it's been used and is being used to see whether a completely different mode of action might have a beneficial effect on modifying the progression of Parkinson's. So everybody is thinking outside the box, looking at mechanisms, looking at enzymes that are potentially implicated in the pathophysiology of Parkinson's. Now, I gather from Tracy that the new CEO of Parkinson's UK is very interested in exercise, and we all are, I'm sure. But this is one of the rare beasts which came out in 2022 in the Annals of Neurology, so a very, very good journal, where not only were they looking at the effects of physical exercise on general function and how people felt, which I guess exercise makes us all feel better when we get a chance to do it. But this looked at mechanistic aspects as well. And it's one of the first studies, and I'm not sure how many more there have been, where using functional MRI scanning, they were actually able to show very clear beneficial effects, albeit small effects, small size effects on anaerobic exercise, altering brain function in people with Parkinson's in a positive way. And it was done as a randomized controlled trial too, to boot. Because there's no doubt that there have been many studies carried out thus far by really good colleagues in MDTs trying to show the benefit of exercise against, say, stretching or what have you. I mean, the only study that I think that got across the wire and actually, again, appeared in the New England Journal of Medicine was Tai Chi. That seemed to show a benefit many, many moons ago. But most of the time, we really, really struggle to demonstrate benefits. So this is looking at a mechanistic level, and it gives some hope. Right, so then this is on to the last section now. So this is old dogs and new tricks. So this is a study that was probably one of the ones that Phil and I were brought up on when we were lads. This was looking at a drug that you'll all probably remember called selegiline. And the study was carried out, was called DataTop. And what they've done, and I'm amazed they still had the samples, was to go back, because this was only looked at in 2022. They actually went back and looked at inflammatory markers in these plasma samples using plasma proteomics. And they were actually able to distinguish using that proteomic profile of inflammation versus non-inflammation to distinguish whether people were so-called responders in that study. And the end point there was whether somebody needed levodopa or not, whether they were getting placebo or selegiline. So I guess what the take home for that is it's an old study. It was a very well conducted study. It induced an unbelievable amount of debate in the movement disorder world, which we don't need to go into. But, you know, selegiline is still thought to be a pretty good drug to start somebody on with Parkinson's, because of this possible mild positive neuroprotective or disease-modifying effect. But not only that, that people who seem to do well on selegiline might be actually picked out by this plasma proteomic profile and looking at inflammatory markers. And again, I've not even talked about inflammation, but that is also thought to be another potential target for people with early Parkinson's, where an inflammatory response can be quite marked in the brain. Again, there will be those of you here who've treated people in general practice or even in hospital care who've been familiar with pramipexole and razagiline, and this was the sort of two heads better than one idea. Well, if they're both relatively safe and they both have relatively mild effects, let's put them both together. And this study that was carried out by some very well-known investigators in America and Israel and across the world. And actually, this drug, this combination was proposed by a really great colleague, actually, who sadly passed away just a few weeks ago, called Warren Olenow. Again, Phil may know the name. He was a very kind, very nice man based in New York, and he did a huge amount for drug studies in Parkinson's. And he was a proponent of this approach. Outcome. Coming towards the end, I've talked about amantadine. It's been around since the ARC, really, but it's been used more recently to manage these involuntary movements in people with Parkinson's. And it can have quite a nice beneficial effect if it doesn't cause problems with exacerbation of psychosis and that skin rash I showed you. So Olivier Rascol, who's based in Toulouse, and Margarita Fabry, who's probably is kind of heir apparent there, decided, well, why don't we try it early and give it before people have developed dyskinesias to see if it prevents people from developing that motor complication. And so this Prevalence study, which was carried out in the French Movement Disorder Network, the take home was it did help. It did prevent, as you can see on this, the bottom curves here, that actually those patients that received amantadine had a lower cumulative frequency of dyskinesia over the course of the study. So this is really just being processed really now in terms of the implications for practice. But it was quite a nice and a notable outcome. It was a significant primary outcome measure there. And then apomorphine, which has again been around a very long time. And as you know, it's not, although the name is confusing, it's not morphine as such. It's a very dirty drug actually in terms of its chemical effects. But sleep in Parkinson's can be a real problem. And so in this study, which was produced just back in 2022 as well, in the Lancet Neurology, it was used at night. And they used this sleep scale, and it's quite a nice graphical representation on the right here of how apomorphine in the red led to improvements versus placebo in things like this overall quality of night sleep. And you can see these are quite significant effects. You would expect that, but you know, apomorphine is not the easiest of drugs to give. The nurses in the audience or listening in will absolutely know that, with nodules and all sorts of other issues. But this is, again, something that's kind of formalized, which is in a way that we've not really used apomorphine thus far. Okay, so, I mean, I think just coming to the end, Parkinson's it's had a stormy journey in terms of the pharma companies. There's been billions of dollars spent on developing new diagnostic tests and treatments. And, you know, I've tried to highlight that we've got some promising agents coming through. Oh, there's been some sad failures as well, and we've all been gutted to see those negative outcomes. And it's also led to us thinking, well, why don't we reevaluate some of our older drugs as well? And they've generally had more favorable outcomes, if I'm honest, but then they've shifted the dial far less. I think what I've also tried to tell you is, and I know you know this from other walks of life, there's an urgent need for better biomarkers and more sensitive means for evaluating disease progression. The biggest fear is that we may have actually canned some drugs because some of the markers that we're using, which are based on good old-fashioned clinical testing, may have been drop too readily because these tests are not so sensitive. I think that's unlikely, because if they had a significant enough benefit, you should have picked it up on most of the scales, clinical scales. But having a blood-borne biomarker or an easy to perform imaging test would make a huge difference in this area. And we're very, very close, I think, to getting to that sort of area in a more widespread way as well. But having said all of that, and the thing that got me into neurology in the first place is the fact that high quality clinical evaluation, both in terms of history and examination, should never be overlooked. So I would like to think, and in fact there was a thing I read in the paper many moons ago, was that neurologists will probably be one of the last professions to succumb to AI. So thank you very much for listening.
Oh, while David has a glass of water, questions? What we'll do, sorry, for our Zoomers, if you can summarize the question and then give the answer, is that okay?
I will.
Thanks. Sorry.
There was some in the news a few years ago, a woman that's patients now. I wondered if that going here, what also the clinical detective.
Yeah, that's a great question, and yes, you're absolutely right. And then there was stories of dogs being trained as well, weren't there, to actually look. I mean, I think that I don't know exactly what it was she was smelling as such, but there is a change in the sweat composition of people with Parkinson's. So it's not just cystic fibrosis have changes in that. There are changes in the autonomic system, and the composition of sebum changes in people with Parkinson's. So where it's currently got to, I honestly don't know the answer, because I guess what you're saying is, could that form the basis of an early test if you could get an objective marker of some, you know, like not relying on a lady to take her along all the time, or a dog even, but whether you could actually have some sort of equipment that would detect that. I think, and in fact, Phil, I think Chris Kobliecki in Manchester was,
Manchester who are doing it.
Yeah. yeah, I think that
As in,
it's not a PET scan. It's not a PET scan.
I think we do.
Oh.
There's
There's a number of aromatic.
they've identified two in particular. I'm not quite sure what they are.
Mm.
And these two things are really promising. And so they've got these two.
They've picked out two chemicals.
And so what they're sort of looking at now is whether they can be involved with, obviously, there's the doggy story, but there's also patch testing.
Oh, yeah.
Which might come out.
Yeah.
And I think the sort of theory is that because these are fat soluble products, that you're getting, if you like, a little insight into what is across the blood-brain barrier there. And so therefore, it's opening up another avenue into potential
Interesting. Yeah, I've not heard the latter. I've not heard that latter piece, but that's interesting. Yeah.
Okay.
Thank you very much. What about the usual risk factors, social deprivation, obesity, poor record of employment?
Yes. So the
Parkinson's POX found on the
No, sadly not. So the question is whether other risk factors, for example, obesity, social deprivation, lower socioeconomic status, predisposes one to getting Parkinson's. The honest answer is, the short answer is, to the best of my knowledge, no, they're definitely not. Anybody can get Parkinson's disease. So I think be they wealthy, and I've certainly seen my fair share of those, or be they poor, and I've certainly seen my fair share of those in and around Newcastle, and worldwide again. I mean, I think what I would say, and it's a bit of a cop-out in a way to your question, but you know, if you look in Africa, people don't live that long, sadly. And therefore, because Parkinson's is a disease of aging, they're probably carried away with infectious diseases or other things at a younger age. But people in Africa still get Parkinson's, particularly if they live long enough. And that would be one of the poorer areas of the world. So, and the other thing that again we always used to say is, you don't see, it's interesting, you don't see many obese patients with Parkinson's. It can happen, but and one of the last studies that I did before I moved over into leading the faculty in Newcastle was actually looking at orexin and ghrelin and seeing the effect, because ghrelin in particular is a really interesting pleiotropic hormone that can not only control appetite, but also has effects on the brain as well. So there might be something in that as well. And there's something about premonitory weight loss as well before Parkinson's kicks in some cases. But obesity per se, you're thinking of like Alzheimer type risk factors, that doesn't manifest.
So we've got a question from a Zoomer, and then yourself.
Yeah,
Excellent.
Sarah Watson asks, at what point should we be referring our younger patients, as such a long waiting list for neurology, or should there be an early PD clinic?
Oh gosh. Well, no. So the question from Sarah was, should we be getting should we be referring younger patients with Parkinson's? Should there be a fast track potentially younger people with Parkinson's because of the long waiting list for neurology? That's clearly only got to be here in York, of course. No, I think it's a problem, and I mean, you don't want to be either reverse ageist about it or not. I will say, and I mean, we can all have examples. Funnily enough, I was talking to a public patient group just the other day, like last week, telling them a story about a young lady who came to see me, and I remember vividly, and I better be careful because we want to compromise, but she'd been to see a colleague of mine, and because of her age, the penny just hadn't dropped that she got Parkinson's. That's the problem, and you must hear and see that all the time. And so, of course, it's like, is it Parkinson's? But it's having that penny to drop that it might be Parkinson's. the evaluation and the treatment done, and that left her quite, she took a while to get over that, actually, I have to say, and then went on from well, very interesting experimental therapy carried out in another center. But I think that the problem is that we need more neurologists, is the bottom line. In this country, I still think, well, there's no doubt the vast majority of people with Parkinson's are seen by care of the elderly physicians. And in many cases, they are seeing people of all ages with Parkinson's, including younger people too. Now, I have nothing against my colleagues in care of the elderly. They're some of my best friends, and actually I've had more affiliation with them over many years working in Parkinson's perhaps than with neurologists. They're excellent, but it's not really, it's not ideal. It's not what we would want. So I think that we basically need more neurologists is the key thing. And again, I know I'm going to be very contentious here, but I think that primary care is massively, massively overstretched, and I'll be the first to admit that. But I do worry a little bit about the sort of skilling or de-skilling even at times of people in primary care, colleagues in primary care, to be able to recognize telltale signs and symptoms. And I think that part of it, I would suggest, would have to go back a step to sort of think, well, hang on, you know, filtering out a little bit, both positively and negatively, because I remember my general neurology clinics used to be just filled with people with, it was almost hunt the physical sign. There was rarely a physical sign, rarely. And rarely was there a really significant organic diagnosis that I would be managing. Whereas on the flip of it, you worry, well, are there people with real symptoms and signs that, you know, with a few skills and a few tests, simple things that people can do in the waiting room, would that enrich and allow GPs to send the right patients through as well? Because, yeah, I could go on, because, I mean, I used to do single-handedly in Durham, the neurology clinics there. And the waiting time, when I inherited it from a guy that Phil and I both know, who's a superb neurologist, and he was faster than I was, I would have to say, in seeing people, rightly or wrongly. He had a waiting time for routine neurology that was probably up to about 48 weeks when I took over. I then gamely tried to restructure and change things, and I don't think I made much difference at all in the time that I was in Durham. I was then replaced by two neurologists who both were doing more clinics, and guess what? The waiting list didn't change at all, because all that happened was the GPs around realized there was more neurology service, so the threshold dropped and they referred more. So that's the problem we face. I think it's complicated, and it's a great question.
Can I ask your question?
We believe there's evidence that these neuropathological changes in alpha-synuclein actually start in the periphery and then spread rostrally. So, three things. One, could you comment on?
Yes.
Because two, it suggests, I mean, is there a gut origin for Parkinson's disease? And three, I mean, could you block those changes? I mean, would there be a new treatment approach to actually sort of halt the disease from?
That's better summarize the question.
I will summarize the question. Are we all right for time?
We're okay. We'll take this.
Great.
We'll go and have
No, because I that's a wonderful question. So I'll play the question back. So the question is, does Parkinson's disease begin in the gut? And is there any merit? Is there any truth in that? And can we therefore, if that is the case, use that as a potential way of getting at Parkinson's at an early stage? So the short answer is that. So you're obviously a proponent of the Brack hypothesis, because it was Heiko Brack that actually came up with this. Are you a pathologist yourself by any chance? No. I mean, it's an incredibly persuasive hypothesis. So yes, you can do deep. You've got to go quite deep on the biopsy from, say, a rectal and higher rectal biopsy. You've got to go quite deep to get at the relevant areas. But yes, you can.
now.
Yes, I know. Sort of, the cheeks have been clenched, but for the audience who are listening here, Tim is rocking up and down on his toes, clenching his buttocks. But no, I mean, there have been biopsies done, and you find alpha-synuclein in the gut, and you can also find alpha-synuclein in the gastric mucosa. and you remind me of me at a meeting in Sydney. And I remember this well when it was the big international annual Parkinson's meeting. And there was a guy stood up and he talked about this. And I said to him, I said, is there any evidence that people back in the day, because it would have to be back in the day, who'd had a total vagotomy and pyloroplasty, had a lower incidence of Parkinson's compared to those who had not had V&P? He said, that's a great question, and I don't know the answer. About 5 years down the line, the Swedish registry, of course, because they've got this amazing index, haven't they, over in Sweden, looked at that, and they found that people who'd had total V&P had a delayed onset of Parkinson's compared to those who had not. And so the short answer is, yes, I think there is something in that. They've even taken it a step further, looking at microbiome changes in the bowel of people with Parkinson's. I think that's really difficult, and that may be a red herring, mixing metaphors, but that may be it's not sure whether that's cause or effect. But the idea of the centripetal transmission of alpha-synuclein, because it is a bit like people have use like a prion hypothesis, where you get synuclein passing into a cell. And then, yeah, you've got me going now, because there's all sorts of interesting stuff I didn't really mention about brain, you know, the transplants that people have had, and somebody then dying with a fetal transplant, and then finding synuclein in the transplant that they received, abnormal synuclein. And the clear implication was that the synuclein in the host brain led to what we call permissive templating, and led to an abnormal synuclein forming within the newly acquired brain cells from the fetus, the fetal transplant, which is just remarkable. And there is a clear thought that because the REM sleep behavior disorder is mediated in the pons, in sleep centers there, that is one of the earliest features. And Levy described Levy bodies actually in the locus ceruleus, not the substantia nigra. So the idea is that there is, as you rightly say, this caudal to rostral transmission of alpha-synuclein, literally passaging from one cell to the next as it moves upwards. So and then finally, the last point is, you saw that slide that I showed where people with olfactory dysfunction and REM sleep behavior disorder may fare worse. There's been some evidence that if you could also say, well, the olfactory mucosa is another mucosa, a bit like the gut, it may be that that is where synuclein is forming in the olfactory mucosa, and there's evidence that it does, and that's going in. And that, because of the shorter way it goes in and where it goes in into the brain, might make it more likely that those people with more pronounced olfactory dysfunction are at higher risk of cognitive impairment with their Parkinson's. And there is some evidence to suggest that.
Any other questions?
Just ask, I read somewhere that there was a higher incidence of severe vitamin D deficiency in people with Parkinson's to be a diagnosis. Is that true? And is it significant?
So the question is about vitamin D deficiency in people with Parkinson's. So so it's not severe vitamin D deficiency, but interestingly, work that I think Richard Walker did, if I remember rightly, who's a colleague of mine at North Tyneside. He looked at this amongst many others around the world. And there is something in vitamin D metabolism being slightly deranged in people with Parkinson's. And that has led people to try vitamin D supplementation and the like to see whether it makes any difference. But the honest answer is it's not really had an effect as such. And again, it's hard to know. Some of it is a bit of cause and effect. You know, is it like a reverse causation, because people might be less likely to go out because they're depressed, because that's a prelude. So, but statistically, abnormalities, you're absolutely right. Vitamin D abnormalities have been identified in people with Parkinson's.
Okay, well, I think I'll draw it to close and invite John to come and give us the vote of thanks. You can have a sit down.
Yes, I'll have a slurp.
Good evening,
friends, colleagues, it's lovely to be back. The piece of paper that you have in front of you, if you've got one, says that I'm a new member, which is true, but only in as much as I felt the need to resign from the society, having been a member since alpha-synuclein was published, for reasons that you may or may not be aware of. And I would just like to take the opportunity to thank Tim and the officers of the society for being incredibly brave in dealing with an extraordinarily difficult situation, with, for me, a very satisfactory outcome in that I'm back. And I was a bit surprised to be asked to give this little note. I just walked in off the street, and it's people say, "Oh, do you need a pencil and paper?" Oh my God, I've got to pay attention. The reason I'm here is that he and I go way back, not quite as far back as Sunderland winning the FA Cup, but quite a long way back to the mid-80s. At that time, a very young, incredibly enthusiastic and able SHO in medicine expressed an interest in movement disorders. And I remember you saying it very, very clearly, and lo, it's come to pass. And he's clearly demonstrated himself to be a very expert boy from the black stuff. Not at all a Mickey Mouse neurologist. I think it would be impossible to summarize the things that you've told us. It was fascinating to hear about drugs I last heard of when I was a medical student, even before we met. It's amazing how things come around. The diagnostic difficulties, I feel your pain. You try asthma, mate. That's incredibly hard too. But absolutely fascinating. And I think for me, the real take-home message is the hope. I think, you know, we've all met people with Parkinson's in our careers, and it's so difficult. You know, the look on the face when you'll get Bill or Pam to come and speak to somebody, and oh my God. You know, and to know that there is hope for these people and that such clever people are working so hard on it is really incredibly encouraging. And I want to thank you personally and on behalf of everybody for all your efforts. And in an unashamed plug, our daughter's a psychiatry trainee in the Northeast who wants to do liaison. So if you need a bit of help with the mental stuff, she starts a liaison in February. Bleep her. Ladies and gentlemen,
as long as it's between 9 and 5.
Oh, you won't. Well, it's what it's the road to now, mate. It's not like what we did. It's not like what we did. So, David, it's a pleasure to see you after far too long. Thank you for coming down and braving horrendous Yorkshire weather. It's been absolutely fascinating. We're all very grateful for you for coming. Thanks very much.
Thanks.